Hello students. In today's session, we will be discussing about the biochemical genetics. The learning objective of this session will be to understand about the inborn error of metabolism, to understand how these are classified, and to understand how to use these biochemical assays for diagnosing inborn error of metabolism. So, inborn error of metabolism occurs due to block at some point in the normal metabolic pathway, which is caused by a genetic defect of a specific enzyme. So, individually, they are rare, but collectively, they are quite common. The prevalence is 1 in 800 to 1 in 2500 of live births, and it represents about 20% of acute illnesses in the newborns as per the developed countries data, and 5% of the developmental delay occurs because of inborn error of metabolism. So generally, these disorders are progressive, often unrecognized because of the protean clinical manifestations, overlapping phenotype, and because any organ can be involved because of this inborn error of metabolism. And it is important to remember that some of these are amenable to treatment and have good outcomes. And these AIIMS can manifest at any age depending upon the enzymatic residual activity. Some of them remain asymptomatic throughout the life because of either the milder defect or they are not exposed to the necessary stress which is required to manifest these conditions. So it's important to understand that these inborn error of metabolism, they have all types of inheritance, recessive, dominant, X-linked, mitochondrial. So it is important to take a good family history to ascertain the type of inheritance. So how does this IM occur? So if suppose this is a metabolic pathway, A is converted to B with the help of enzyme AB, B is converted to C with another enzyme BC. So if this BC is not there, deficient because of any genetic defect, then B will not be converted into C. And B can get converted into an alternative metabolite, resulting in the production of toxic metabolites. So the presence of these abnormal metabolites act as a metabolic signature for a particular type of disease, and we need to capture those metabolic signature by means of the investigations that we plan to do. So why is it important to suspect and diagnose these IEMs early? Because many are treatable, and rapid diagnosis and early instigation of therapy for those disorders which are amenable to therapies associated with successful outcomes, and it reduces the morbidity and mortality. Some are untreatable, so it is important to establish the diagnosis in the proband, because it will be helpful for the family in planning future pregnancies. For some of the patients are quite sick without any immediate diagnosis. So there also the IMs remains the topmost differential diagnosis, because it is important, then it becomes important to store the sample at that point in time, because that is the last point. And having if we have a specific diagnosis, it is possible to counsel the family for the future risk by providing prenatal diagnosis in the subsequent pregnancies. So high index of suspicion is a must for these disorders. So there are the important point to remember is that many a times these IMs are not diagnosed because, as I said, that they have protein manifestation. Diagnosis is non-specific, and one needs to exclude the common illnesses. And as the presentation is non-specific, so the inborn error, the diagnosis of IEMs is considered only secondarily. And most of the time, the physicians are unfamiliar to the diagnostic test. So they will obtain inappropriate samples, collect the samples inappropriately, and store or transport them in an inappropriate manner. So it is important to understand how to collect, which sample to collect, how to collect, and how to store or transport a particular sample. So if we have a high index of suspicion and know how to correctly transport the sample for lab evaluation, then probably it is possible to make a specific diagnosis. So these IEMs can be classified into three categories. The first and foremost is intoxication category, which is quite common in any emergency setting. It occurs because of the accumulation of toxic compounds proximal to the metabolic block, like we saw in that metabolic pathway. So here we have initial symptom-free interval, and these babies are usually normal at birth, but they can have acute, intermittent, chronic, or acute and chronic course of illness because of the triggers which are present. And these triggers could be fasting, fever, infection. They generally do not have any dysmorphism, and we have certain diagnostic tests available which helps in making a specific diagnosis. We will see in the subsequent slides. So here we measure the amino acids, organic acids, or acyl carnitines depending upon the type of disorder that we are considering. These disorders are usually treatable because there are triggers, so triggers can be avoided. You have something is deficient, so you can provide that. You have toxins, so you can remove that. So these disorders are usually treatable. Then the second category is energy deficient, where there is deficiency in energy production or utilization in liver, muscles, or brain or heart. The onset in these cases may be prenatal, and sometimes they appear normal at birth. The involvement, they have multi-system involvement, and again here the diagnosis, they can have acute, chronic, or acute and chronic course of illness. They may also have triggers like in intoxication type, and dysmorphism may or may not be present. Again, depending upon the category of disorders, whether it is mitochondrial disorders, or it is a fatty acid oxidation defect, or cytoplasmic energy defect like glycogen metabolism, certain diagnostic tests can be performed in terms of metabolic assays, function studies, or enzyme assays. And some of them are treatable or modifiable by means of specific diet. Third category is a complex group of disorder, which the disorders which disturb the synthesis or catabolism of complex molecules. So it's basically an organelle based abnormality. Here the onset may also be prenatal. They are sometimes normal at birth, but here the course of illness is chronic, and it is permanent and progressive. There are no triggers at all, and the dysmorphism is quite common. The diagnosis is, as it is an organelle based, so diagnosis can be made by means of enzyme assays and some other type of special tests like in congenital disorder of glycosylation. And very few of them are treatable at this point in time, and the treatment which is available is very costly. So this is a classification and prevalence of inborn error of metabolism as per the classification given all, wherein you can see that the mitochondrial disorders and the US cycle defects are the common, it belongs to the common category. And the, uh, out of these, the treatable ones includes the vitamin metabolism disorder, the urea cycle defect, and the disorders of carbohydrate metabolism. The common presentation of these three categories include either the neurological abnormalities, which can present as encephalopathy or seizure, and when these patients have encephalopathy or seizure, they may have metabolic abnormalities in terms of hyperammonemia, acidosis, or ketonuria. So then we can classify them into as maple syrup urine disease or urea cycle defect or organic acidemia. But if there are no metabolic abnormalities, then the differential diagnosis is falls into non-ketotic hyperglycemia or molybdenum cofactor deficiency. In the presence of hypoglycemia, we need to see whether it is hypoketotic hypoglycemia or not. If it is so, then depending upon the presence of ketosis or not, we can classify them as fatty acid oxidation defect or glycogen storage disorder. Some of them may present with cardiac dysfunction, and if it is hypertrophic cardiomyopathy without any specific dysmorphism, then one would think of mitochondrial respiratory chain defect. But if it is associated with macroglossia, then tongue fasciculation, then one can think of Pompe disease. We can also have dilated cardiomyopathy, and then it points towards Barth syndrome. There are certain lysosomal storage disorder where cardiomyopathy may be present as a part of feature, then but there some additional dysmorphism will also be there. The other organ involvement is liver. So hepatic dysfunction is commonly seen in patients presenting with having galactosemia or fructosemia, tyrosinemia, or mitochondrial respiratory chain defect. The main characteristic feature of complex molecule disorders, as I said, is dysmorphism, and these are the recognizable phenotype. And the category, the various categories belongs to this particular group of disorder includes lysosomal storage disorder, peroxisomal biogenesis defect. So when we are looking at patients with IEM, then the general approach that is being followed is when to suspect an IEM, and if we are suspecting an IEM, what type of metabolic investigations should be performed. So when do we suspect an IEM? Obviously, first and foremost, we will start with history. And if there is any history of unexplained progressive course in terms of encephalopathy, neurological deterioration, jaundice, cataract, intractable seizures, failure to thrive, we have to think of inborn error of metabolism. Any child presenting with developmental delay or regression, if there is any history of sudden unexplained sibling or neonatal deaths, this E. coli sepsis, which is very much characteristic of galactosemia, though there can be any other sepsis also, any behavioral abnormalities, positive family history or consanguinity, and presence of triggers like presence of fasting, infection, exercise, or any catabolic state can precipitate a particular type of small molecule IEM. So these point towards a wide range of disorders, both intoxication as well as energy based disorder. And most of the time, because of the consanguinity, most of the time they are autosomal recessive in inheritance. So we can also have some antenatal clues in terms of acute fatty liver of pregnancy or presence of HELP syndrome, which can be a feature of long chain dehydrogenase deficiency. Then one can also have a history of specific food aversion, like aversion to sweets or aversion to high protein. Then it particularly points towards hereditary fructose intolerance or urea cycle defect. But so generally, as I said, that most of these intoxication or energy type will not have any specific dysmorphic feature, except that they may be just sick looking, they may have some abnormal movements, they may be some unusual odor, and they may have some skin or hair changes. So but for lysosomal storage disorder or for the complex group, the phenotype is recognizable, and dysmorphism is very much appreciable. Like in this slide, it shows various type of mucopolysaccharidosis and mucolipidosis. So based upon the patient's clinical feature, the dysmorphic features, a possibility of lysosomal storage disorder or diagnosis of mucopolysaccharidosis group can be made. So now I'll be mainly focusing on the various types of metabolic tests that are available. As I said, that the main hurdle in making a specific diagnosis is to obtain the correct sample in a correct manner and correct in a timely manner. So what are the basic metabolic tests that are available? So we remember this by a name of an acronym, which is GLAC, where G stands for glucose, L for lactate, A for arterial blood gases and ammonia, and K for ketone. So this simple 5-item blood test is very, very helpful in narrowing down towards a specific type of inborn error of metabolism, whether it is intoxication type or it is energy deficient type. In addition to this, we need to have this complete blood count, LFT, RFT, electrolytes, because when we are dealing with a metabolic disorder, these may be altered, and there may be presence of associated sepsis, because sepsis also act as a catabolic factor to precipitate any kind of inborn error of metabolism. So then we also need to do CPK and plasma uric acid, because these are altered in specific type of IEMs. And urine reducing substance is a very non-expensive, easy to do test, bedside test. So this is a wheel which is given by Garanta and Smith et al., which shows that if we simply remember these five GLAC thing, then we can easily classify a sick newborn into various kind of category. For example, if there is presence of acidosis, ketonuria, or mild hyperammonemia, then we know that we might be dealing with a diagnosis of organic acidemia. Similarly, if there is presence of if there is no abnormality, then probably it is a case of maple syrup urine disease or galactosemia or non-ketotic hypoglycemia. Or likewise, if we have only hyperammonemia, then it is we are probably dealing with urea cycle defect, and this red color shows that the ammonia is going to be very very high in UCD as compared to the organic acidemia. The degree of hyperammonemia would vary depending upon the type of inborn error of metabolism. So it's just a clue towards various type of tests. Like for complete blood count, it is important because if there is neutropenia, it may point towards organic acidemia. In UCD or aminoacidopathies or mitochondriopathies or lysosomal storage disorder, we may have deranged LFT, RFT. In glycogenolysis or rhabdomyolysis or fatty acid oxidation defect or mitochondrial disorder, we will have CKemia. The plasma uric acid can be high or low depending upon whether it is Leishman syndrome or molybdenum cofactor deficiency. Then we have altered vitamin B12 and homocysteine levels in cobalamin defects. Then lipid profile is an important metabolic investigation which should be performed in patients who are suspected to have glycogen storage disorders. So if there is a clinical suspicion of Wilson disease or something related to the metal copper metabolism, then one need to do the specific estimation. So these are the tests, like serum prolactin is elevated in neurotransmitter disorders. So these are certain tests which are done when there is a suspicion of a specific disorder. The confirmatory tests include again a battery of tests, but these confirmatory tests means that we are trying to look for those metabolites which may be present in an abnormal amount because of a metabolic defect. So these include acyl carnitine analysis, organic acid analysis, amino acid analysis, plasmalogen evaluation, or CSF based test, and some enzymatic diagnosis or tissue diagnosis for mainly for the complex disorders. So but bottom line is that even if for all these functional assays, it is important to have a DNA diagnosis, because the ultimate aim of doing the DNA diagnosis is to provide a specific diagnosis in the subsequent pregnancies, and for which these biochemical assays may have limitations during the prenatal period. So again, I'll just tell in brief about various type of specialized tests, how should they be used, and what are the precautions that needs to be done. So as I said, that these are the confirmatory tests, but we need to remember three categories of core test, which is simple colorimetric evaluation in the urine, which we have been reading since very early time during MBBS. And then we have amino acids and the organic acids, carnitine and the acyl carnitines, lactate, pyruvate, and non-esterified fatty acids and the ketones. Apart from these three tests, which are very important tests and usually done in any type of acutely presenting IEM, the others include enzyme assays, as I said, that is important based upon the clinical suspicion. Likewise, congenital disorder of glycosylation, purine pyrimidine and orotic acid estimation, sugars, polynols, glutathione, mucopolysaccharidosis, VLCFA. So these are all tests which are not done for all, and it is based upon the clinical suspicion. Whereas these three tests are mainly done for those disorders which are presenting acutely or appears to be, if the disorder is falling into the category of intoxication type or the energy deficient type. So when we are talking about these four tests, there we talk of the samples. The useful samples for doing these four tests are either blood sample or the urine sample. In some situation, we can obtain CSF or bile depending upon the type of abnormality that we are suspecting in that particular case. So the blood samples should be obtained in the most physiological state and should be clearly labeled whether it is fasting, postprandial, or after exercise. Sometimes loading or the challenge tests are required to be done, like glucagon challenge test, but it has to be done under the supervision of a metabolic specialist. But nowadays, most of these tests are usually not done because they may be risky. Then the urine test are done basically to look at the excretion of metabolites in the urine, which is measured in terms of the creatinine output, because based upon the concentration of the creatinine. And urine tests are important because it is less influenced by any metabolic or the nutritional change. It is less influenced by any blood transfusion, and a spot urine sample, a morning void, is good enough because it has high level of metabolite concentration. So the simple test which can be used, colorimetric evaluations of the urine can be used as a bedside or at home for certain disorder, includes first and foremost is the DNPH test, which is done mainly for maple syrup urine disease, and mainly for the, because the diet in maple syrup urine disease requires very careful monitoring. So it can also be done by the caregivers. It detects the urine alpha keto acids via the formation of hydrazones that precipitates out of the solution. The second test is urine reducing substance, which differentiates between the glucose related and non-glucose related reducing substance, and it is helpful mainly for the galactosemia. The third important test is cyanide nitroprusside test, which is usually done for the homocystinuria. And L-rich aldehyde test is useful for porphyria. Sulfide test is another important test for which can be done for a child who is labeled as HI without any history of birth asphyxia. So in this condition, this sulfide test can, if it is positive, then one can suspect sulfite oxidase or molybdenum cofactor deficiency. But we need to remember that it may be falsely negative if the urine samples are left at room temperature for several hours. So it is important to process the sample as soon as possible, and at least 3 times should be performed before it is labeled as negative. Then the other important test on urine is urine organic test, urine organic acid evaluation, which the major source of organic acid in mammals are amino acids, lipids, and carbohydrates. And these organic acids are optimally analyzed in urine because they are usually efficiently excreted via the kidneys and have higher concentration in urine than any other body fluid. So plasma, serum is not useful for doing the organic acid evaluation. And this is done by using gas chromatography mass spectroscopy, and a minimum of 10 ml of random or the morning urine is required. One should not put any kind of preservative, and mostly dry ice is used for the transportation. So these urine organic acid is useful for detecting organic acidemias, amino acidopathies, fatty acid oxidation defect, and the mitochondrial disorders. Coming to the blood test, first and foremost is evaluation of amino acid, estimation of amino acid. And again, here as we can use blood, CSF, and the urine as well for looking at the amino acid depending upon the disease which we are targeting at. So for blood, one needs to obtain plasma, which is separated from 1 to 2 ml of heparinized blood. Fasting amino acid analysis should be done, or 4 to 6 hours after the last meal. This is the best timing for doing the test. One should clearly label what type of, what is the timing of that particular test and try to maintain the same. And for energy metabolism disorders, both postprandial as well as the fasting samples are required. So these tests are mostly done in an acutely sick patient who is there in emergency, or in patients with where who's already on diet, protein restricted diet, or receiving special type of special diets. The various methods are used to evaluate to estimate these amino acids, and it includes ion exchange chromatography, high performance liquid chromatography, ultra performance liquid chromatography, or a combination of this UPLC along with mass spectroscopy. In the advantages that it provides a very rapid analysis, and liquid chromatography or mass spectroscopy. So these are the various methods which can be used and which have varying specificity and sensitivity, and in terms of high throughputness, and in terms of rapidity. So these techniques vary from. So it is important to know that once we have the plasma amino acid in place, like for example, one amino acid may be elevated in different types of disorder. For example, if you talk of phenylalanine, there may be elevation, very high elevation of phenylalanine, and which can happen in PKU, whereas the levels may not be that high in biotin synthesis disorder. So it is important to estimate the primary amino acid as well as the secondary abnormalities in various other amino acids, so that a specific diagnosis can be made. For example, another example is tyrosine. It may be elevated in tyrosinemia type 1 and as well as in the hepatic failure. However, if we look at the urine succinyl acetone, the other marker by means of GCMS, so then it will not be there in hepatic failure, but will be present in succinyl acetone. So the message is that it is not the just the one test which will always be useful in clenching a particular type of biochemical diagnosis. Rather, it is a combination of various tests which helps in making a specific diagnosis. So this is another example. This was a child who had developmental delay, regression in encephalopathy, seizures along with the brisk reflexes. So a clinical possibility of non-ketotic hyperglycemia was kept, and the CSF was obtained. And when we do the CSF at that particular point in time, plasma sample is also taken, and the ratio is seen. So in a non-ketotic hyperglycemia, in the late onset type, the ratio is between 0.06 to 0.1. And this is the chromatogram that shows the level of CSF glycine and the plasma glycine. So in this child, you can see that it was slightly elevated. So it is 0.11. So it is important to remember what is the abnormal level at that particular age. So if we look into the neonatal value, then this may be taken as normal. So age is very important when we are looking at various types of metabolite levels. Then the other metabolites are acyl carnitine, which can be measured by taking a dried blood spot, 3 to 6 dried blood spot on a filter paper, which can be transported at room temperature. Or we can take 1 to 2 ml of EDTA blood, where the plasma is rapidly separated and it is transported on dry ice. So acyl carnitines are mainly useful for estimating the for organic acidurias, fatty acid oxidation defect, and amino acid disorders. So as we saw with amino acids, various types of amino acid levels and the different diagnoses based upon the combination of various biochemical abnormalities. Similarly, acyl carnitine levels alone will not give total information about the metabolic disorder. So here also we need to combine with the GCMS or any other metabolic estimation so that a specific diagnosis can be made. For example, C3 is one metabolite which may be elevated in several conditions like methylmalonic acidemia, propionic acidemia, or cobalamin defect. However, if we do the GCMS and look into the various metabolites of GCMS, then one can easily differentiate whether it is MMA, propionic acidemia, or cobalamin, depending upon the presence of homocysteine level, presence of MMA, presence of propionic acid metabolites. So it is important here also that once we are doing the acyl carnitine levels, we need to look into the various other metabolites elevation, and so that a specific diagnosis can be made. Then comes the estimation of carnitine. Because in certain organic acidemias and fatty acid oxidation defect, carnitine is used, and it can result in the intracellular carnitine is used, and it can result in secondary carnitine deficiency. So presence of reduced serum carnitine is a potential indicator of IEM. So it is a very good marker to indicate whether IEM is present or not. And the quantification can be done for the total free or the esterified carnitine in serum or plasma by MSMS. Then comes the lactate, pyruvate, and the ketone bodies. These are very important because these three, once we estimate all these three, then we can have an idea whether we are dealing with a pyruvate metabolic defect, citric acid cycle defect, gluconeogenesis, hepatic glycogenolysis, oxidation of fatty acids defects, or ketogenic defect. So these three are important, but it may not be very easy to estimate all these three. We need 1 ml serum or plasma, which should be shipped on dry ice so that lipolysis is avoided. Then it can be classified, it can be quantified in plasma, urine, or CSF. Again, as with other metabolites, nutritional status must be known for these patients. And for acetoacetate or the pyruvate level, the blood should be immediately deproteinized with perchloric acid at the bedside. So simply obtaining the sample into plasma or into EDTA vial or a plain vial will not help for the ketone bodies and the pyruvate level. It has to be deproteinized, which may not be available all the time. Then comes NEFA, which is non-esterified fatty acid. It can also be analyzed on plasma or serum. It also provides an important information on lipid catabolism and ketogenesis. And estimating NEFA alone will have not much meaning if it is not, if the ketones are not made. It is essential for any patient with acute metabolic coma or presenting with hypoglycemia. So after having this brief understanding of various types of test analytes that can be measured, let's see how these are useful apart from diagnosing a case of inborn error of metabolism. So LCMS-MS is one technique which can be used for newborn screening, which can be used for doing the targeted metabolomics as we saw, which can be used for enzymatic assays, which can also be used for measuring the biomarkers for lysosomal storage disorder. And if we do modifications of this LCMS-MS by adding TOF, um, the various modifications of this LCMS-MS can help us, can do the untargeted metabolomics for and can identify new biomarkers, and also can help us in understanding its effect on the various metabolic pathways. So this has been used successfully for newborn screening for last 5 decades, and it has been, nowadays LCMS-MS is being used because it has better sensitivity and specificity. So these are the list of newborns various disorder which can be detected by using LCMS-MS. You will have different sessions on newborn screening, and this is just to show that this is the area from where the sample should be obtained. So a word about targeted versus untargeted. Targeted means that we do routinely, that we are trying to look for single abnormality by doing a particular type of assays, whereas untargeted metabolomics means that we are looking at thousands of metabolites, and we are trying to understand the various biological pathways which can result in those abnormal metabolites. So in targeted metabolomics, we are looking for the specific metabolite to make a diagnosis. we will have few false negatives, but there may be many false positive, and the specificity may not be high for each and every disorders. Whereas for the untargeted metabolomics, one is trying to detect many metabolites in comparison to control. One can pinpoint biochemical alteration in the metabolic IM patient and in the control, and one uses metabolic signatures, not the single metabolite, the single result, but the metabolic signatures for making a diagnosis. And and once we are using those signatures, which is a combination of various metabolites, then it increases the specificity also, because we know that the metabolites that are there in a particular pathway may not be representative of that particular condition. Untargeted metabolomics probably has more specificity in terms of because it's a kind of signature, and it involves various types of linkages with various other pathways, and it also helps in diagnosing various new IEMs and understand the various mechanisms of particular underlying IEM. However, untargeted metabolomics is presently being used in research settings because of the lot of noise that one receives with these metabolites, and requires a lot of standardization. So now coming to the most important part, whenever we are analyzing these metabolites on any blood sample, the sample collection becomes very important. So for TMS sample, one needs to collect the samples on a specific type of filter paper, which is SS903 filter paper. And it is a kind of a critical sample which is obtained in during the golden hour. One needs to obtain the sample prior to the start of treatment, so that the samples are not diluted because after initiating the intravenous fluid. One should collect the sample only on one side and see that it looks same from both the side, and ensure that it is dry. So here this picture shows that there are one should take at least 3 spots, 3 to 6 spots are taken, which are collected in full circle with a diameter of about 15 millimeters. So you can see that this is the front side and this is the back side. These are air dried on a stacker for about 3 to 4 hours, not with a dryer. It has to be air dried. So these are the certain set of filter paper which are not correctly obtained. So there is a sample overlay. You are taking one is this spot shows that there are multiple spots which are overlaid over each other. This spot shows that there is lot of supersaturation. This spot shows that it is not blotted in a proper manner. Like here, we could see that both are seen in an equal manner. This spot shows that there are clots in between. You can see that this is a dark circle, this is the light circle, dark circle, light circle. So layers are seen in the center of the dried blood spot, and these are the insufficient. It is not 15 millimeters, so insufficient spot for the analysis. So one need to collect the spot in a correct manner while sending a sample for LCMS. Then comes the collection for urine GCMS. As emphasized earlier, one should have freshly voided or first spot, first void sample is the best sample. It should be collected without preservative, and one should make sure that using the Wattman 3 or 4 filter paper for obtaining the sample for GCMS. And if many a times, because we are obtaining the sample for sick babies who may not be urinating who may be comatose, so the urine sample can be collected on from the diaper when the paper is snugly fit onto the nappy, and then the urine, it soaks the urine and it can be analyzed. So in so in this is a case where we will see that how other modification of various tests can be useful. So this was a case, 4-year-old female who was asymptomatic, who had asymptomatic neonatal period, became symptomatic since 6 months of age, had developmental delay, febrile seizures, and multiple GTCS. There was history of episodic decompensation, which was precipitated by fever, and evaluation showed presence of hyperammonemia. So this picture is collectively suggesting isolated hyperammonemia, episodic decompensation. Trigger is present that it is a kind of small molecule intoxication type of IM, and most likely urea cycle defect. So here were abnormal and here showed presence of trichorrheitis nodosa. So it again suggested that it could be yeah, either citrullinemia or ASS deficiency, late onset type. So in this case, amino acid was done, amino acid analysis was done using UHPLC, which showed presence of glutamine, which is a marker of hyperammonemia, and the citrulline, which was mildly elevated. So again, as we see here in this pathway, there is, if there is a block, there is elevation of ASS. If there is a block here, then there is an elevation of citrulline. So the elevation of citrulline can be there in ASS, in ASS deficiency also, and ASL deficiency also. So these were the two differentials. But how to differentiate between the two? One need to do the estimation of arginosuccinic acid, which may not be possible by standard UHPLC. And for this, urine LCMS or plasma LCMS has to be done to characterize whether it is ASS deficiency or ASL deficiency. And in this child, these levels were quite high. So LCMS is sensitive enough to detect these ASA levels, and it can detect the very low levels of ASA in plasma. And in this case, the final diagnosis was made as ASL deficiency, and prenatal diagnosis could be offered in the next pregnancy. So this is another case where who was referred at the age of 5 years for intellectual disability, had autistic features, had seizures and visual problem, had some bit of facial dysmorphism. As you can see, had coarse features and had pudgy hands and feet. Had nystagmus and hypotonia with brisk deep tendon reflexes, with and also had abnormality in the fundus in terms of pigmentary retinopathy and extinguished VER. Family history was significant in terms of recurrent abortions, and the lady visited at 6 weeks of gestation in view of all these abnormalities in her previous child. So again, in this case, we did not have specific diagnosis, but if you carefully look at this picture, then there is presence of inverted nipple, and inverted nipple is a hallmark of congenital disorder of glycosylation. And for this, that's the reason transferrin isoelectric focusing was done in this patient, and it was shown to be abnormal in this, and this pattern was suggestive of a CDG type 1, and this was confirmed by NGS. So point is that in case of any such abnormalities, the specific type of test is decided based upon the clinical picture. So in this case, transferrin isoelectric focusing was ordered because there was a clinical suspicion. So this is another lady who presented at 26 years of age. So you see that it's not that the AIIMS will manifest during childhood only. So this lady presented at 26 years. She was normal till 26 years of age. She had developed chronic progressive neurological illness in terms of multifocal cortical myoclonus, postural tremulousness, restriction of eye movements from the age of 24 years. She had preserved cognition. There was no family history of similar illness, but she had postural tremors, bilateral cherry red spot. There was no slurring of speech, and she also had mild hepatomegaly. So presence of bilateral cherry red spot was characteristic, because we know that it is not present in each and every patient with the inborn error of metabolism, and we have specific diagnosis for differential diagnosis for cherry red spot. Her MRI brain was normal, so this patient was diagnosed to have sialidosis type 1 based upon NGS results. So sialidosis has different it's a spectrum of disorder and can be divided as type 1 and type 2. Type 2 form has mainly the joint manifestation and the facial coarseness, which can be seen in this particular child. So so this patient had neuraminidase deficiency. As I said, the diagnosis was made based upon the NGS analysis, and as this enzyme estimation could not be done in the lab because it may not be available at each and every lab, so one can use this screening test by using thin layer chromatography to look for various pattern of oligosaccharides. So in this picture, this is a picture which I've taken from internet, wherein you can see the pattern of various sugars at different levels. So if the pattern is like this and this band is seen at this level, then it suggests that it is sialidosis. So oligosaccharide analysis using thin layer chromatography may also be useful and can give clue towards this oligosaccharide disorders. So this is another case who was a 10-year-old male child, had generalized hyperpigmentation, and MRI showed presence of um, uh, suspicion of adenoleukodystrophy. And then obviously the biochemical test is done to estimate the plasmalogen levels using stable isotope dilution based GCMS, and it showed abnormal levels of elevated C22 the C22 was sorry elevated C26 levels and the altered ratio of C24 to C22. So this was quite specific of X-linked adenoleukodystrophy, and the diagnosis here, the TMS and LCMS-MS will not be no, abnormal. So you will have normal GCM, normal TMS, but you need a specific test to do the plasmalogen assays. So it's important to correctly classify the disorder clinically and then order the subsequent investigation for subsequent biochemical investigation. So the key message from this talk is that it is very important to classify the IM based upon the clinical um, phenotype and the simple biochemical investigations that are available in any hospital, simple bedside biochemical investigation. One need to understand and know the method of sample collection, the timing, the storage, and the transport methods. A combination of biochemical assays are required to make a diagnosis of different types of IEMs, and molecular testing remains the gold standard. Thank you.